Good morning and welcome to this presentation about evidence-based treatments for depression in children and youth. My name is Christopher Belanci. I'm a child and adolescent psychiatrist at Tufts University School of Medicine and the medical director of the National Technical Assistance Network for Children's Behavioral Health. This webinar is supported by a National Technical Assistance grant provided by the U.S. Department of Health and Human Services, Substance Abuse and Mental Health Services Administration. And I'd like to especially acknowledge my research assistant, Katie Stockman, for all of her work in preparing the content used in this presentation. Depressive disorders significantly impact functioning and are characterized by sad, empty, or irritable mood, and somatic, meaning bodily, or cognitive, meaning mental changes. This presentation will focus on two common depressive disorders in children, major depressive disorder and disruptive mood dysregulation disorder, also known as DMDD. The clinical presentation, etiology, and treatments differ, and so they will be taken on in two parts. There have been changes since DSM-4, with the onset of DSM-5 coming out in 2013. Previously, depressive disorders were combined with bipolar and related disorders. There are also two new disorders in the DSM-5 chapter on depressive disorders, premenstrual dysphoric disorder and disruptive mood dysregulation disorder. While premenstrual dysphoric disorder is possible in adolescents, it won't be a focus of this presentation. Disruptive mood dysregulation disorder represents a major change in the diagnostic options with regard to children and will be explored at length. Another change is that dysthymia, which is known as a chronic state of depressive disorder, is now called persistent depressive disorder. Depression is characterized by the following disorders. There's disruptive mood dysregulation disorder, or DMDD, as mentioned, major depressive disorder, persistent depressive disorder, formerly called dysthymia, premenstrual dysphoric disorder, substance or medication-induced depressive disorder. So this is when the depression is the result of abusing or taking illicit substances or secondary to medications being prescribed, typically for medical conditions. Depressive disorder due to another medical condition. An example of this would be hypothyroidism, or other unspecified depressive disorder or unspecified depressive disorder. You'll notice the absence of not otherwise specified, a former NOS category that was available in DSM-4 that has been done away with in DSM-5. Major depressive disorder is characterized by 5 or more symptoms of depression having to be present during the same 2-week period that causes clinically significant distress or functional impairment. And that's a key to determine between depression and sadness or grief. These symptoms must include either depressed mood or loss of interest or pleasure in all or almost all activities. In children, the mood can be irritable instead of sad. Other symptoms can include significant weight loss or weight gain and decreased or increased appetite nearly every day, insomnia or hypersomnia, meaning being excessively sleepy or sleeping too long nearly every day, psychomotor agitation or retardation nearly every day, so that's an agitated physical state or a depressed or retarded physical state. And this is a change from baseline. Fatigue or loss of energy nearly every day. Feelings of worthlessness or excessive guilt nearly every day. Difficulty thinking, concentrating, or making decisions nearly every day. And recurrent thoughts of death, suicidal ideation, or suicide attempt. And mnemonic for remembering the features of major depressive disorder is SIGI-CAPS. S stands for sleep, I stands for loss of interest, G stands for excessive guilt, E for changes in energy state, C for changes in concentration, A for appetite changes, P for psychomotor, agitation or retardation, and S for presence of suicidal thinking or actual suicidal acts. There are many specifiers to consider in major depressive disorder. You want to qualify whether or not this is a single episode, meaning there's no past history of a depressive disorder, or if this is a recurrent episode. And then you also want to rate the severity between mild, moderate, and severe. Or whether there's presence of psychotic features, and then there are remission specifiers followed by additional specifiers such as with a seasonal pattern or seasonal affective disorder, or with anxious distress. All of these qualifiers help to determine the course of intervention, which is going to be the focus of this conversation. Other considerations would include the fact that many bipolar illnesses first begin as a depressive episode, sometimes more than one depressive episode. And so you have to look carefully at whether or not there's a family history of bipolar illness, as starting an antidepressant can predispose to manic activation. Depression with psychotic or mixed features increases later risk for bipolar disorder. And psychotic features can also indicate possible future development of schizophrenia. It's always important, particularly working with children, to differentiate from developmentally appropriate sadness when making the diagnosis of depression. Sadness is a commonly experienced emotion. Even periods of being down can be developmentally normal, particularly in adolescence. A key diagnostic feature is that symptoms need to last most of the day, nearly every day, and for a 2-week period. There clearly needs to be a demarcation and a departure from baseline functioning. And looking at functional impairment is another key in differentiating between sadness and depression. What is sadness over a loss, such as death or divorce, versus depression? When does sadness become complicated bereavement? The American Psychiatric Association, which writes the DSM-5, notes that the predominant effect of grief is feelings of emptiness or loss, while in major depression, symptoms are more consistent with persistent depressed mood or inability to anticipate happiness. Grief is often tied to thoughts of the deceased, and people with grief can experience humor or positive emotions, whereas those with major depression often cannot. Another distinguishing feature is that with grief, self-esteem is preserved, but not so with major depression. A bereaved person can have thoughts of dying in order to join the deceased. These aren't necessarily symptomatic of depression, because in depression, thoughts of death are related to feelings of worthlessness or inability to cope. So the focus in grief and bereavement is on the actual person who has been lost. It's not uncommon to hear children talk about wanting to see their dog in heaven. This is a reflection of the loss, not of depression. The depressed child might instead say, "My dog died. It's my fault. I'll never be able to care for animals." Clinical presentation differs based on age. In the preschool age group, you may hear young people saying, "Nothing is fun," or "I'm bored." These children aren't engaging the play-based interactions that you'd expect of them. Their outlook is gloomy. They lack self-esteem. "I can't draw," for instance. School-age children who used to love sports may find reasons to not go to practice. Children with depression may fail to meet expected weight gains. These are just examples of what might present at each age group. An adolescent may experience mood swings, which are normal, but persistent depressive feelings and functional impairments are markers for a major depressive disorder. Looking at prevalence, meaning how often this depressive disorder occurs in each age group, starting with the preschool age group, depression has been validated in children as young as age 3. 40 to 60% will have a comorbid disorder, including attention deficit hyperactivity disorder or oppositional defiant disorder. Epidemiological studies of 2 to 5-year-olds in pediatric practices in North Carolina showed a rate of 2.1%. So it's a relatively rare occurrence, but can occur. School-age children, ages 7 to 15 years old, 2% of boys and 4% of girls reported a major depressive disorder in the past year. Adolescence is really where we see a significant increase in the prevalence of depression. In 2014, 11.4% of the population aged 12 to 17 years experienced at least one depressive episode. Females' lifetime prevalence was almost 16%, more than twice that of males. Depression can appear at any point, but the likelihood of the onset increases with puberty and peaks in the 20s. Comorbidity. There is a frequent co-occurrence with panic disorder, OCD, eating disorders, and substance use disorder. This is a nice chart that summarizes what I was just describing in the last slide. So on the left, in the orange box, you'll see that the overall prevalence of major depressive disorder in the past 12 months was 11.4% in 2014. And the next section on the gender differences shows you that very significant difference between very high female prevalence rate of 17% versus the male rate of under 6%. And then looking at age, you'll see that with each age increase from 12 to 13 to 14 to 15 to 16 to 17, you see a corresponding increase in the prevalence rate of depressive disorders. And then on the right-hand side, we have the prevalence broken down by race. Risk and prognostic factors. So temperament is a risk factor, particularly negative affectivity or a negativity in one's general demeanor. In the environmental risk factors, adverse childhood experiences represent a risk factor, but are also a precipitant of major depression. Though there doesn't need to be specific precipitant prior to the major depressive episode, merely having an elevated ACE score or adverse childhood experiences predisposes one to a greater risk of major depression in their lifetime. And then, of course, genetic and physiological risk factors. So first-degree family relatives, those are parents or siblings with major depressive disorder, are 2 to 4 times more likely to experience a major depressive disorder than the general population. So if your parent has a major depressive disorder, compared to the general population, you're 2 to 4 times more likely to experience a depression as well. But the risk may be greater for early onset and recurrent depression. The assessment starts with a diagnostic interview and then obtaining collateral information. This is particularly important when you're working with children, to speak with the pediatrician who may have a longer longitudinal history with the family, with the school, with permission, seeing whether or not there's a change in how the child is functioning in the classroom, obviously with the parents or caregivers, and the child themselves. And there are various screening tools that can be very effective, including the Patient Health Questionnaire for Adolescents, or PHQA, designed for children between the ages of 11 and 17 years old. It's a well-validated and free tool for depressive screening in adolescents. The Beck Depression Inventory and Children's Depression Inventory are both widely used in research, but they can be costly to purchase. And the U.S. Preventive Services Task Force found inadequate evidence for depression screening tools in children under the age of 11. Treatment. Treatment is difficult and requires partnership between the clinician, child, and family. 30 to 50% of youth are non-responsive to the first treatment approach, including selective serotonergic reuptake inhibitors, or SSRIs. Those are medications known like fluoxetine or Prozac, Celexa, Lexapro. CBT, which is cognitive behavioral therapy, and the combination of cognitive behavioral therapy and a medication such as an SSRI. Choosing your treatment approach and first-line options differ by age and development. So in the preschool age group, you're really thinking about a dyadic approach, meaning you're going to focus on treating both the child and the parent together. An example of an evidence-based preschool age psychotherapy would be parent-child interaction therapy. This is the long-established and effective treatment for disruptive behavior in childhood, which has been adapted to treat depressive disorders. It's a short-term or 14-session manualized program whereby a trained therapist helps parents engage their child in ways that increase emotional regulation, coping skills, and combats negative thoughts. It utilizes a one-way mirror, an earbud to microphone communication system, where the therapist who's behind the one-way mirror can coach the parent on ways to engage their youth and pull for better emotion regulation, teach coping skills, and combat their negative thoughts. The child learns the skills, and the parents learn how to reinforce those skills. Another preschool age evidence-based intervention is Child First, Child and Family Interagency Resource Support and Training. This is more of a wraparound approach, which is home-based. It's a psychotherapeutic program for families with children from birth to 6 years. It can also include pregnant women or parenting moms. Lasts between 6 and 12 months, and the program seeks to prevent or reduce children's emotional, behavioral, developmental, and learning problems, and prevent or reduce abuse and neglect by their caregivers. The evidence base for the selected featured evidence-based therapies all came from NREP, which is SAMHSA's National Registry of Evidence-Based Programs. Continuing with Child First, it's constructed by a two-member team consisting of a care coordinator and clinician. The care coordinator links the family to local activities and providers. The clinician is trained to provide trauma-informed child-parent psychotherapy to build parenting skills and improve the parent-child relationship. The team meets with the family weekly or more if needed. The program has a strong evidence base for reducing maternal depression, but not as strong for reducing child internalizing behavior problems. Multi-day trainings are necessary to provide the services, and the cost of these trainings varies. Another option when you get to the school age group is cognitive behavioral therapy, or CBT. There are also modular approaches to therapy for children with anxiety, depression, trauma, or conduct problems, known as MATCH. MATCH addresses not only anxiety, depression, trauma, or conduct problems, but also related issues or challenges that may emerge during the therapy. It was developed from a review of meta-analyses of evidence-based treatments and selected the commonly used components within each of those EBPs. Modules include components on cognitive behavioral therapy, parent training, coping skills, problem solving, and safety planning. It's all about teaching skills. For adolescents, cognitive behavioral therapy for adolescent depression has a strong evidence to support its efficacy. CBT-AD adapts cognitive behavioral therapy steps and tools to adolescents' developmental needs. It uses more concrete examples, explores autonomy and trust issues, and focuses on cognitive distortions, affective awareness or regulation, problem solving, and social skills, and it typically takes 12 to 16 weeks. Attachment-based family therapy is a model based on interpersonal theories of depression. It proposes that the quality of family relationships may precipitate, exacerbate, or prevent depression and suicidal ideation, and that ruptures in these family relationships, such as those due to abandonment, neglect, or abuse, or a harsh and negative parenting environment, may influence the development of adolescent depression. Families with these attachment ruptures lack the normative secure base and safe haven context needed for an adolescent's healthy development, including the development of emotion regulation and problem-solving skills. It's designed for adolescents between the ages of 12 and 18 and involves semi-structured protocol with clearly defined process and goals. The evidence that it's effective for treating depression and suicidation and reduces anxiety comes from the SAMHSA NREP registry. Interpersonal psychotherapy is another option for adolescents. It's a brief, time-limited psychotherapy that seeks to reduce symptoms of depression and improve social functioning. It's been well established for the treatment of depression developed in the 1960s with roots going back to Bowlby's attachment theory and focus on the importance of relational bonds for mental health. Its efficacy in treating adolescent depression was demonstrated in 1996 and has been replicated since. There are other therapies identified as effective, as defined by the SAMHSA NREP site, including adolescents coping with depression, culturally informed and flexible family-based treatment for adolescents, relapse prevention, cognitive behavioral therapy, and a new emerging area of interest are computer-based treatments, including this one, computer-based cognitive behavioral therapy, or beating the blues. There are other therapies that have less rigorous evidence, either because they've demonstrated efficacy in a limited number of studies, or they have the studies are non-randomized controlled trial designs. And the NREP site describes these as promising practices versus evidence-based practices. These evidence-based practice databases, including NREP, the California Evidence-Based Clearinghouse, Blueprints, and others, are being constantly updated as new interventions are investigated and existing programs are replicated. So the survey of the data that I've provided thus far is only as good as today and should prompt one to check these sites periodically, or even better, sign up to get new listings from these sites so that you're staying current with the field of evidence-based practice. I'm now going to switch to discussing medication management for depression. Psychopharmacological interventions aren't considered first or second line treatment in preschool-age children. There are no FDA-approved medications for the treatment of depression in the preschool age group, which is generally defined as under age 6. The Treatment of Adolescent with Depression study, or TAD study, provided the evidence for the current standards of treatment. It included 439 adolescents between the ages of 12 and 17 years old with major depressive disorder who were randomized to one of 4 study arms. So one arm was medication alone, and in this case it was fluoxetine, also known as Prozac, cognitive behavioral therapy alone, or medication plus cognitive behavioral therapy, or a placebo pill made to look like the active medication fluoxetine. The rates of response for fluoxetine with cognitive behavioral therapy were 71%. That was the highest response group. And so generally, the message from the TAD study is medication and cognitive behavioral therapy in combination are the most effective interventions. Medication alone showed a 60% response rate. Cognitive behavioral therapy alone showed a 43% response rate, and the placebo showed a 35% response rate. And this is not uncommon in children's or adolescent medication trials. Children and adolescents are highly suggestible, so it's not a surprise that we have a very high placebo response rate. If you tell children, take this medicine, you're going to get better, in many cases they do. And so we see high response rates, which makes the statistical significance challenging to show that the difference between the 35% placebo response rate and the fluoxetine alone 60% response rate is statistically significant and not just due to random. The combination treatment of fluoxetine and CBT was the most effective and also had significantly faster time to response. Another large study of adolescent depression was the treatment of resistant depression in adolescents, or TORDIA study. This included 334 adolescents with depression who did not initially respond to an SSRI medication. It used randomized assignment to a medication switch alone or a medication switch plus cognitive behavioral therapy over a 24-week period. There were 4 treatment arms. In this case, the first arm included just a switch to a different SSRI. The second arm was switched to a different SSRI plus cognitive behavioral therapy. The third arm was a switch to a non-SSRI antidepressant medicine called venlafaxine, which is trade name Effexor, or a switch to venlafaxine plus CBT. The conclusions from this study: for adolescents with depression not responding to an adequate initial trial with an SSRI, again, it was the combination of cognitive behavioral therapy and switching to another antidepressant, either the SSRI or venlafaxine, resulted in a higher rate of clinical response than did a medication switch alone. So it didn't matter which medication you switched to. What matters was the addition of cognitive behavioral therapy. So again, we have a second large study showing that it's the combination of an antidepressant and cognitive behavioral therapy that has the greatest efficacy, which is really the most important take-home, I think, from this entire presentation. Rarely should a child be put on an antidepressant without a combination of cognitive behavioral therapy if you're going to expect the greatest efficacy or the greatest response for adolescent depression. The likelihood that a treatment will lead to remission is evident fairly early in the treatment. So in the Tordia study, at 6 weeks, patients whose symptoms would remit versus those whose symptoms would not started to show divergent treatment trajectories. And at 12 weeks, those with treatment response predicted a 3-fold higher likelihood of eventual symptom remission as compared to non-responders. So this slide is highlighting that pretty early, between 6 and 12 weeks into the treatment course, you'll know whether or not you're going to get remission from this treatment intervention. And if you're not seeing that, it may be time to switch, or certainly if you're not already providing cognitive behavioral therapy in addition to a medication, it's time to start that cognitive behavioral therapy course of treatment. What is concerning about the Tordia study is that the remission rates at the end of 24 weeks were only 40%. Anhedonia, or the inability to experience pleasure in normally pleasurable activities, is uniquely predictive of a longer time to recovery in adolescents in the Tordia trial. Some additional combination trials, meaning combination of medication management and typically cognitive behavioral therapy, have also been conducted. In 2015, there was a study of 144 youth. This one included younger children down to age 8 up to age 17 with major depressive disorder, and again showed cognitive behavioral therapy following acute medication management significantly reduced relapse rates as compared to those receiving medication management alone. So we have a significant evidence base to show that its combination treatment of cognitive behavioral therapy plus medication is superior to either condition alone, both for the initial response and the maintenance of remission of symptoms. Cognitive behavioral therapy plus medication management during treatment period of 30 weeks resulted in a relapse rate of 9% versus a relapse rate of 26.5% for those receiving medication management alone. And then a recent meta-analytic study published in Lancet, which reviewed 34 trials, including 5,260 participants in those 34 trials, looking at 14 different antidepressant treatments. The only medication that showed statistically significant efficacy compared to placebo was fluoxetine. Looking at suicide risk factors, adolescence through young adulthood is the peak time for the emergence of suicidal thoughts and behaviors, and adolescence can be particularly challenging to engage in consistent treatment. Comorbid borderline personality disorder, smoking, past substance use disorder or alcoholism, family history of suicidal acts, head injury, and childhood abuse history all increase the risk for a suicide attempt. And it's generally understood that females attempt suicide more, but males end up committing suicide more. And that leads to male gender, living alone, and access to lethal means such as guns, and feelings of hopelessness being associated with risk, a high risk for completed suicides. Obviously, past attempts or past threats of suicide increase one's suicidal risk, but most completed suicides aren't actually preceded by failed attempts. Treatment for suicidal ideation and self-harming behaviors. Recent studies looking at outcomes of dialectical behavioral therapy for adolescents versus enhanced usual care, that would be just kind of care as usual in a community clinic for adolescents with repeated suicidal and self-harming behaviors, showed that dialectical behavioral therapy far outperforms usual care during the 19-week treatment period. And after 1 year, the outcomes were not significantly different. Adolescents in the dialectical behavioral therapy arm largely maintained their gains in reducing depression and suicidal or self-harming behavior. But what was notable was that the clinical status of those in the usual care arm also improved significantly, which might imply that suicidal ideation or self-harming behaviors are self-remitting or transient, or that the usual care provided is actually more efficacious than what one would presume based on the earlier data. Two significant conclusions are noted: that while dialectical behavioral therapy led to a more rapid decline in symptomatology, the usual therapy that most in the usual care group were engaged in was also effective over the year-long period, and adolescents with repeated suicidal and self-harming behaviors are in fact treatable. I'm now going to discuss disruptive mood dysregulation disorder. DMDD is characterized by chronic, severe irritability and frequent episodes of extreme verbal rages and or behavioral discontrol that are inconsistent with the child's developmental level. So the highlight and the distinction here is that DMDD is a chronic irritability. It's not a change from baseline. So where you have major depressive disorder, you've got a child that's functioning relatively well, and then you see a clear departure from that typical level of functioning. Here, with DMDD, you have a chronic severe irritability, and overlaying that, these episodes of rages that can be very impressive and out of context with whatever the stimulus is, or the lack of any stimulus. The episodes occur 3 or more times a week in at least 2 settings. So it's important that it can't just be at home. It needs to be at home and school, or home and in the community, or in school and the community, but it's got to be 2 out of the 3 settings that the child functions in. And they have to be grossly out of proportion to the provocation. The symptoms need to be present for more than 12 months and not absent for more than 3 months in that time frame. So again, we're really describing a chronic state of severe irritability present most days in 2 or more settings that the child is functioning in for at least 12 months. The diagnosis shouldn't be made before age 6 or after age 18, and symptoms must have been present by age 10 years. So while you can diagnose DMDD at age 13, historically you would have to see that the symptoms were present by age 10. And the diagnosis cannot coexist with oppositional defiant disorder, intermittent explosive disorder, or bipolar disorder. It can coexist with other disorders, including major depression, ADHD, and conduct disorder. If the child has had manic or hypomanic symptoms ever present, the individual cannot be diagnosed with disruptive mood dysregulation disorder. We're really trying to distinguish those children that are having bipolar illness, those children that have depression, and those children that have this other chronic state of severe irritability overlaid with episodic aggressive episodes. This new diagnosis was created in part to address concerns related to the overdiagnosis of bipolar disorder and the rapid increase in the use of atypical antipsychotic medication, which appears correlated to the increase in the diagnosis of bipolar disorder. Before the existence of DMDD, NIMH had studied a disorder they labeled severe mood dysregulation, or SMD, and that really was the precursor for the DMDD diagnosis. In SMD, it was required that there were recurrent temper outbursts, a persistent negative mood, which unlike DMDD can include depressed mood, whereas DMDD it's irritability, and the presence of at least 3 hyperarousal symptoms, such as pressured speech, racing thoughts or flight of ideas, intrusiveness, distractibility, insomnia, or agitation. These hyperarousal criteria were included because it was these symptoms in persistently irritable children that often led to a concern about mania. Also, the age of onset for SMD was before age 12 years, and a maximum symptom-free period was 2 months. So how does one differentiate between a developmental disruptive mood dysregulation disorder from pediatric bipolar disorder? In the DSM-5, the diagnosis of bipolar disorder is only used in cases of episodic presentations of bipolar symptoms. There must be discrete episodes of mood deviation, both manic symptoms and depressive symptoms. Elevated or expansive mood and grandiosity are characteristic of bipolar disorder, not disruptive mood dysregulation disorder. It's the severe and chronic irritability that distinguish DMDD. Oppositional defiance symptoms are common in disruptive mood dysregulation disorder, but mood symptoms are characteristic of DMDD and not common in oppositional defiant disorder. And also, again, DMDD has to be seen in at least 2 settings, whereas oppositional defiant disorder can be diagnosed if symptoms are present in just 1 setting. Most of the children who meet criteria for DMDD will also meet criteria for oppositional defiant disorder, but only the DMDD diagnosis is given. Whereas only 15% of children with oppositional defiant disorder would meet criteria for DMDD. And again, in these cases, DMDD would trump ODD as the diagnosis. DMDD is not a diagnosis made prior to age 6 years, and so we're trying to be very clear that this is not just severe temper tantrums. Temper tantrums in the preschool age group are relatively common, with 80% of preschoolers being found to have had severe temper tantrums in the last 3 months. Almost half of school-age children were also found to have had severe temper tantrums in the last 3 months. So it's important to note that for DMDD, the irritability has to last 12 months with no break for at least 3 months. And it has to be severe in nature and functionally impairing, as all psychiatric diagnoses should be. So what are some of the functional consequences of DMDD? So family and peer relationships and school consequences can be quite marked and severe. School-age youth with disruptive mood dysregulation disorder experience significant social impairments. So their relationships with their parents, with their siblings, and their teachers were very complex and complicated and challenging. And frequently, children with disruptive mood dysregulation disorder resulted in school suspension and increased service utilization, such as both mental health and physical health services. Dangerous behavior, including aggressive behavior and suicidal ideation or suicide attempts, are common with this condition. The prevalence of DMDD is not yet available, so certainly when we look at cultural ethnographic variables, we don't have any good data. Because it's a new diagnosis, the prevalence is still being determined. There is data on the rates of chronic and severe persistent irritability, which is the central feature of DMDD, which suggests that the 6 to 12-month period prevalence is about 2 to 5%. It's likely that rates are higher in males than females, and higher in school-age children than in adolescents. An analysis of 3 large studies showed that DMDD prevalence rate of around 1% for school-age children and around 3.3% for preschoolers. Very few children with severe chronic or non-episodic irritability develop bipolar disorder. Instead, these children are at risk to develop unipolar depression or anxiety disorders in adulthood. Bipolar disorder is quite rare prior to adolescence, with less than 1% of the population showing this condition at that age group. And it increases into early adulthood, where we have roughly a 1 to 2% prevalence rate in adulthood. Disruptive mood dysregulation disorder is more common in younger children and becomes less common as the children age. The presence of comorbid conditions is more common with disruptive mood dysregulation disorder than many other pediatric mental health disorders, and the breadth of comorbid disorders is also greater than with other pediatric mental health conditions. In a large nationally representative sample, almost 93% of disruptive mood dysregulation disorder youth met the criteria for another DSM-4 disorder, including mood disorders, conduct or oppositional defiant disorder, ADHD, and substance abuse. In the NIMH studies, National Institutes of Mental Health, youth with SMD had extremely high rates, over 75% of ADHD, and oppositional defiant disorder, as well as anxiety disorders in 58% of the cases. The most common comorbidity is oppositional defiant disorder, although again, if ODD is present, only the diagnosis of DMDD is given. Other common comorbid conditions with DMDD include major depression, ADHD, anxiety, and autism spectrum disorders. Risk factors for DMDD can include temperamental factors, like we discussed for depression, and genetic factors, so family histories of anxiety disorders, depressive disorders, and substance use disorders put a child at greater risk for developing disruptive mood dysregulation disorder. The assessment is entirely through clinical interview, engagement, observation, and collateral communication. There are no well-validated rating scales to assist in the diagnosis of disruptive mood dysregulation disorder at this time. So choosing a treatment approach, the first-line options, because it's relatively new diagnosis, there's limited information on diagnosis-specific treatment. The current thinking is to maximize treatment of ADHD, which is so highly comorbid in this population, and then manage residual symptoms that are typically mood or anxiety-based. Treatment is informed by evidence-based interventions for disorders that share core features, like I mentioned, depression, ADHD, oppositional defiant disorder, and anxiety disorders. Psychotherapy for disruptive mood dysregulation disorder brings us back to the discussion of cognitive behavioral therapy, as it's effective in treating depression and anxiety and can be adapted to working with children who have mood dysregulation. There are also cognitive behavioral therapy that can be used to help children identify negative thoughts and build frustration tolerance. And CBT also teaches coping skills and helps children reinterpret agitating stimuli. Parent training for DMDD works directly with the parents to develop more effective ways to respond to their children's moods and behaviors. It's possible that some of the parent-child interaction approaches may be effective for DMDD. Parents learn to anticipate triggering events, create predictable routines, and consistent responses to the behaviors, and reward positive behaviors. And then again, computer-based training is starting to show efficacy. There's early evidence to show that children with DMDD misinterpret ambiguous facial expressions, generally seeing them as angry, and experience greater fear when viewing neutral faces. Computer-based training can help correct this problem and may be an aid in treating DMDD. Medication treatment, stimulants have been used to help irritability in children with comorbid ADHD. And again, there's a lot of comorbidity of ADHD with DMDD. And antidepressants, research is ongoing as to whether antidepressants may be helpful. Second-generation antipsychotics should be reserved only for the most severe cases associated with physical aggression, property damage, or self-harm. Aripiprazole and risperidone are FDA approved to treat irritability in children diagnosed with autism and are sometimes used to treat children with disruptive mood dysregulation disorder. There are significant risks associated with these second-generation antipsychotic medications, including weight gain, metabolic abnormalities, sedation, movement disorders, hormonal changes, and suicidal ideation. So using second-generation antipsychotic medications require that the prescriber check blood work, which can be challenging to obtain with some children. And some general considerations for all of our services and therapies is to ensure that these evidence-based interventions are available within your service array and accessible. There are challenges to our workforce development, including training, coaching, supervision, and certificate programs to support access to evidence-based therapies. And of course, fiscal issues, where some sites are using incentives for implementing evidence-based practice. There are costs associated with training and ongoing professional development, which require attention in the system to ensure providers to whom the youth may be referred are capable of implementing the most effective programs for depressive disorders, especially in light of that 10 to 15% prevalence rate in adolescents. We also need to ensure that care coordinators and RAP facilitators are aware of the need to access relevant evidence-based practices for depression. So when planning with a youth, family, or team, it's important that the team be thinking about how to access and ensure that the youth is receiving evidence-based treatments for their depressive disorders. Building capacity for peer-to-peer support in a system and service array so that there are other relevant supports readily available, especially to adolescents who may be struggling with depression and other challenges and may be less inclined to access services in support of their care. Coming up next in this series on evidence-based treatments for the major psychiatric disorders in childhood and adolescence will include presentations on attention deficit hyperactivity disorder, obsessive compulsive disorder, bipolar disorder, post-traumatic stress disorder, anxiety disorders, psychotic and impulse control disorders. There are also guidelines for identifying and selecting an evidence-based practice for implementation in community-based settings that will be developed by the Technical Assistance Network in support of this evidence-based practice series. There will be an introduction to implementation readiness, recommendations on assessing and preparing organizations to implement an evidence-based practice, and a practical tool called Ready to Implement, helpful in identifying and selecting evidence-based practices and strengthening organizational readiness to implement an EBP. The purpose behind this series is to highlight what works in children's behavioral health for each of the conditions that I've described, and then supporting those resources will be guidelines for how to select an evidence-based practice that's going to work in your community, how to determine your readiness for implementation, and then how to ensure success of the implementation once you've selected which EBP you might want to promote in your community. I've included some family resources that have been endorsed by the American Academy of Child and Adolescent Psychiatry for your review. Thank you for listening to today's presentation on evidence-based practices and approaches for the treatment of depression in children and youth. This is a presentation of the Technical Assistance Network. My name is Christopher Balanci, and I thank you for listening.